and I are excited to be with you today sharing our story. We hope that you will also share your story with us during the question and answer period. We know that together we can tackle this problem more easily. We've outlined 3 learning objectives that we will accomplish with you today. We will begin the presentation by discussing the impact that patient falls and falls-related injuries have at the individual and organizational level. We will then describe the role that shared governance and a champion model of fall and fall injury reduction can have on outcomes. Lastly, we'll focus on key elements or lessons learned that can facilitate change, which ultimately drives improved clinical outcomes. I'd like to start today's program with a story. I once knew a kind 81-year-old elder who was admitted to a nursing home after suffering a stroke in her home. Her name was Elizabeth. She was expressively aphasic and paralyzed on one side. Before suffering her stroke, she was living in a small community caring for the old people. You see, she had been a caretaker her entire life. The oldest of all of her siblings, she helped to raise her brothers and sisters, and then after marrying young, she found herself a single mother of 4 girls when her husband died in a tragic accident. Despite this, she moved forward with her life and remained in this small town, walking to work and everywhere else she needed to go. In fact, just days before her stroke, she'd walk to church to play the piano and organ. Unfortunately, because of her limitations after her stroke, her family had to place her in a nursing home. It was not long after being admitted to the nursing home that Elizabeth fell and suffered a hip fracture. When her granddaughter, who was in nursing school, went to visit her, she pleaded with her grandmother, trying to understand why she had tried to get up. What was it that she needed? She knew that her grandmother couldn't answer, but she was desperate to find out how to prevent this from happening again. It was at this moment that this soon-to-be nurse developed a passion for preventing falls and falls-related injuries. And that soon-to-be nurse was myself in 1984. I truly believe it was the pain and suffering that I saw in my grandmother that day that continues to motivate me to try to understand this very complex, difficult phenomenon in healthcare. I'm sure each of you have a story for why this is important to you. What we know is that falls happen. We know that they're the leading cause of fatal and non-fatal events in the elderly, and that it's important to recognize that while the elderly and frail are more vulnerable to falling, as well as the very young, any patient at any age or physical ability can be at risk for falls, either due to a physiologic change, the side effects of medications, surgery, and other procedures that require anesthesia. The total cost of falls in 2013 was more than $34 billion, according to the U.S. Centers for Disease Control. Some reports cite that between 30 and 50% of hospitalized falls result in injury. And falls with injury are consistently among the top 10 sentinel events reported, with more than 465 in the Joint Commission Sentinel Event Database since 2009. And 63 of those 465, so nearly 300 of those falls, resulted in death. So falls happen at all ages, and when they do, the individuals that have fallen suffer. Sometimes their injuries are life-changing. So as you know, falls in the hospital setting are a persistent problem across the country. There are many studies that cite a number of patient characteristics, circumstances, and activities that contribute to falls. Patient characteristics that have been identified as risk factors for falling include a recent history of falling, weakness, poor cognitive status, and medications. We also know that when patients attempt to perform activities unassisted, especially elimination-related activities, this accounts for a large proportion of falls in the hospital. We know it's important to note that some studies suggest that elimination-related falls also increase the risk of suffering a fall-related injury. In most healthcare organizations, up to 40% of falls are toileting related. Another study suggests that while up to 1/4 or 25% of hospitalized patients use assistive devices in their homes, there's often limited availability of assistive devices for patients while they're hospitalized. In addition, there are other barriers that emphasize the difficulty of preventing hospital falls and contribute to those fall-related events. We all know that many of our patients don't use the call light because they believe that they don't need assistance with basic activities, such as getting something to drink, changing their clothes, or a more recent phenomenon, at least in our hospital, is reaching for a dropped cell phone. In addition to patient characteristics and what's listed in the 2015 Sentinel Event Alert, there are organizational factors that contribute to falls. One of the factors that are cited in the Joint Commission publication include inadequate assessment. Inadequate assessment often results in the patient not having the right care plan to minimize the risk of falling. We also know that communication failures among team members and between team members and families and patients can also contribute to a risk of fall. We know that not all of our team members adhere to protocols and safety practices. This may include things like not using a bed alarm because the family's at the bedside. Or one of our biggest challenges, our team members not providing contact guard toileting for patients at high risk of falls while they're trying to provide the patient's privacy. Another factor that's listed is inadequate staff orientation or supervision, along with deficiencies in the physical environment. These things can include poor lighting, poor floor surfaces, uneven flooring, or equipment in poor repair. Lastly, the Joint Commission publication speaks to lack of leadership. What we have found here is that if a leader believes that fall prevention is important, their team members do as well. But it's not always easy to juggle the many priorities that our leaders and our clinical team members face. So between patient characteristics and organizational opportunities, there is seemingly an endless number of contributing factors, placing those that we're caring for at risk of falling. This seems like an impossible task. Certainly not something one person can accomplish, or even just a few people. That's why Morgan and I believe that it takes a team of champions, to improve this key clinical outcome. Isabel, the slides aren't advancing again. Thanks, Isabel. So, what's the impact on the patient and family when a patient falls? Here are some facts that we need to keep in mind. Falls are the leading cause of a move to a skilled facility for elder patients, often for long-term. And 20 to 30% of those who fall suffer moderate to severe physical injury when they fall. Falls can result in long-term pain for our patients. Falls that involve a hip fracture can reduce life expectancy by 10 to 15%, depending on the age and other comorbidities of the patient. Older adults who fall are likely to worry about their future and loss of independence. Falls can also contribute to a loss of self-esteem and mobility, which leads to decreased activity and sometimes inability to perform activities of daily living. Because of decreased confidence in physical functioning, some patients who fall are more likely to fall again. How does this impact our patients' families? The effects of a fall go beyond the individual and reach into the lives of family members. We know that families worry about the health, safety, and well-being of their family members. Sometimes there are additional obligations, both financial and caregiving, that are the result of falls. We know that thousands of patients fall every year in our hospitals. I know everyone is as committed as we are to decreasing that impact. We've talked about the impact on the patient, but what's the impact on the healthcare worker? So before we talk about how our team members are affected by falls, let's talk about our team members' health in general. When you look at studies that evaluate the stress of the workers in the United States, 60% of U.S. workers report stress in their current jobs, with 11% reporting feeling highly stressed. That's U.S. workers in general. How do healthcare professionals compare? 69% of healthcare workers report feeling stressed and 17% feeling highly stressed. I'm not suggesting that the only reason our team members are stressed is because their patient has fallen, but these types of events certainly affect the emotional stress they experience. Over the years, I've worked in the area of fall prevention. I've spoken to hundreds of nurses, doctors, interprofessional team members, and nursing assistants. Without exception, they can all tell me about the patients that fell in their care. The emotions they share include anxiety, stress, hurt, and fear. Clearly, patient falls impact our team and our patients. So let's talk about the organizational impact of falls. Falls are the most frequently reported incident in adult inpatient units, with the rate of falls ranging from 1 to 25 falls per 1,000 patient days, depending on the unit represented. A patient fall, so a fall on our watch, can impact patient satisfaction, healthcare ratings, and ultimately, as we noted earlier, team member engagement. There's also a business case for fall prevention. Falls are associated with an increased length of stay, higher rates of discharge to nursing homes, and greater healthcare utilization. One study found that the operational cost for fallers, so the cost to the organization for every patient who fell, those experiencing serious injury, was $14,000 higher than the care for someone who didn't fall. And we know that as of 2008, Medicare no longer reimburses hospitals for increased costs, along with many other payers. Patient falls and falls with injury have far-reaching effects. This often leaves us every day feeling like we're in a balancing act. Healthcare is a challenging environment today. The landscape of healthcare and healthcare delivery is changing. Many of our patients are sicker than they've ever been, with the expectation that their length of stay is shorter than it's ever been, and that they're mobilized sooner than ever. All of this impacts our fall and fall with injury rate. How in the world can we possibly navigate this landscape? There is a roadmap to follow. It's not a secret to fall prevention. What I can promise you is that neither hope nor luck will decrease falls and falls with injury, and fear is clearly not an option. That being said, how can we balance the independence of our patients with a safety plan that minimizes the patient's risk of falls? And how can we mobilize an organizational commitment? What we know in the literature is that a fall prevention strategic plan needs to contain the 4 common components that you see listed on the screen. We know that the right risk assessment tool is an imperative. It's important that you have the right risk assessment tool for your organization and your patient population. You need to consider all settings in which your patients are cared for. At our organization, we have one inpatient adult medical surgical tool with similar questions being asked in the ED and ambulatory setting, but we also have a pediatric risk assessment tool and are piloting a tool specific to our mental health population. Morgan will talk more about this, but it was our clinical nurse champions that told us it was time to change our risk assessment tool a number of years ago. In addition, you have to optimize your environment. This is a constant, ongoing task. It's critical if you're undergoing renovations to be involved early. You need to consider toilet height, grab bars, floor transitions, and lighting, to name just a few key environmental factors. Individualized interventions are equally as important. A one-size-fits-all solution for every patient doesn't work. And last but not least, the education you provide to your patients, as well as your team members, must be individualized and involves teach back. So you may be saying to yourself or your team, we have all this in place, but still we aren't able to achieve or sustain improvements in our fall rates. For our organization, it wasn't until we began tackling the culture through our champions that we were able to truly move the mark. Morgan is now going to talk to you about the culture of team prevention and our champion model of fall prevention.
So as Lynn mentioned, when we began our journey, we had plenty of room for improvement. When we looked at our outcomes, we saw that our fall with injury rate was greater than 0.5. And when you look at NDNQI comparison units, it shows that units in the top 25th percentile have a rate of 0. We knew that we needed to be closer to this mark, but how are we going to get there? We knew that the change needed to involve our culture, and it needed to be organization-wide. So we looked to our colleagues who had improved our pressure ulcer outcomes through creating champions of skin integrity, and they used this model to evaluate our culture. So let's talk more about how these affect our culture related to fall prevention. When we look at our patients, what are the factors that increase their risk? What behaviors do they exhibit prior to falls? What's causing them to fall? What is their knowledge and their belief about their fall risk, hospitalization, and falls in general? Then we look to the nurse taking care of the patient. How does she assess her patient for fall risk, and how does she put that into her workflow for the day? The interventions and tools that she has available also contribute to the culture. And most importantly, what is the nurse's experience and belief about patient falls? This contributes greatly to the culture of our fall prevention. The next level we look at are champions. Unit champions are designed to be experts for their unit. They're responsible for identifying gaps in the practice in their area, as well as provide tools, updates, and education from our champion meetings. We'll discuss this in more detail throughout this presentation. The next level is our interprofessional team. Our interprofessional team provides us with different perspectives and tools related to falls. For example, with a culture that has good interprofessional collaboration, we can call on our pharmacists to talk about what medications our patients are on and how those medications, as well as their side effects, will affect our patients' risk for falls. We can also call on our physical therapy and occupational therapy colleagues to help us identify equipment and mobility strategies that will help us mobilize our patients in the best, most safe way. And finally, we look at our systems and processes. The policies and procedures that we have in place related to risk assessment, handoff, prevention of falls, as well as what we do after a fall and how we apply that to our future practice. Together, all of this creates our culture of fall prevention. So you may be asking yourself, what exactly is this champion? And when you look at the second definition on the screen, it says that a champion is a person who fights or argues for a cause or on behalf of someone else. That's exactly how I view our champions. Our champions are people who fight for patient safety and argue to change our practice to be the best practice related to fall prevention. And they do this on behalf of their patients and also their team members. The champions represent their unit and are typically a bedside nurse or a nursing assistant. They're expected to attend our committee meetings and also to provide accountability to their unit outcomes, to educate their colleagues, to role model best practices, and to be transparent about their falls data. So since most of our champions are made up of staff members, everyone is equal and equally valued, from our nursing assistants, charge nurses, pharmacists. Everyone is viewed equally, and this allows our champions to feel safe to share their knowledge during our meetings. And it's also an asset when they bring things back to their units, because let's face it, it can be a lot easier to hear feedback or to accept changes from a peer than it is from a supervisor. Our champions are also responsible for their fall outcomes, and the goals on their annual performance evaluation would reflect their involvement in fall prevention projects and improvement in fall outcomes in their area. They're responsible for educating their team related to things that we learn in our meetings. Just this year, we trained all of our champions to be competent in use of gait belts when mobilizing patients, as well as made them experts in using our safe lift equipment, with the expectation that they would then go back to their work areas and train all their colleagues to be competent with this equipment as well. Our champions also are expected to role model by displaying behaviors that are consistent with valuing safety and exhibiting practices that reflect best practice related to fall prevention. And finally, they're expected to be transparent, both with the unit and with the committee. On the unit, it's important that they share freely what's going on with the fall committee, what changes in practice might be coming, and also how their unit data compares to hospital-wide data. And vice versa, they're also responsible for being transparent in the committee about what's happening on their unit. If they've had an increase in falls, it's expected that they would talk about what's contributed to it and ask the rest of the committee for help to problem solve. And conversely, if they had a decrease in falls or a success in some other area, it's expected that they would share their best practices so that we can spread this throughout our organization. We're asking our team members for quite a bit, and you might be wondering how we get this level of commitment. Well, many of the champion groups in our organization utilize contracts that outline the expectations of our champions. The contract is signed by the champion and also by the leaders on their unit. This makes a level of commitment clear, and it makes it possible for us to hold the champions accountable, but also the leaders. The champion committee is made up mostly of bedside and clinical staff, but we also have two co-chairs. One co-chair is a staff nurse, and the second co-chair is a nurse educator. The co-chairs set the agenda for our monthly meetings, lead the meetings, and help to establish goals for the year and help us to get to reaching those goals. We also have a director liaison who is our administrative liaison, and she keeps us on track with organization goals and priorities while still giving autonomy to the co-chairs to lead the meetings and to lead the group. At our monthly meetings, we begin with the fall call, and we'll talk about that more later on in the presentation, as well as a discussion of safety topics or safety moments. Then we get to the meat of our meeting, and depending on what's going on in the organization, we talk about many different things. We may talk about a hot topic, like how gait belt training is going, what % of your unit have you trained, and what are barriers, how can we get you to 100%. Or we may talk about onboarding of new staff and how they're oriented to fall prevention in their area. We also talk about new products, like in this sample agenda where we talked about the Posey apron and if we wanted to trial it in our organization and how to begin that trial. We also talk about changes in practice. Recently we talked about our post-fall huddle form, which is a tool that we use to drill down and find contributing factors after a patient falls. And we then apply that to learn from what happened to that patient so that we can prevent falls in the future. So old form was considered to be cumbersome, redundant, and not helpful for finding the actual causative factors. We reviewed some sample post-fall huddle forms and found a more simplified version that we felt was more meaningful to staff and easier to use. Together, we made some edits and decided to implement this for going forward. We also review data at our meetings. We invite our data analyst who provides us with our dashboard data in what I call stoplight format. And what I mean by this is that if the unit is well below the benchmark, they show up in red. If they're just slightly below, they show up yellow. And if they're meeting the benchmark or higher, they're green. So it gives us a quick, easy way to see what units are doing really well and which units might be struggling a little bit. Our analyst also provides us with a drill down of the data in a way that only a data analyst can. This helps us to be able to recognize patterns so that we can draw conclusions necessary to make decisions related to our practice change. And finally, we end our meeting with what we call the top 5. And that's where we discuss what are the top 5 things that we talked about today that we would like to share with everyone. We then summarize these 5 things and send them out to the leadership team as well as to our champions. Our champions can use the top 5 as a way to communicate with their team what they talked about in fall call. After the meeting is where the rubber really meets the road. That's where the accountability to outcomes, the education of their team members, the role modeling of best practices, and the transparency really need to happen. We talked about how we give our champions the top 5 as a tool. Another tool that we use is Toilet Tales. This is used for education related to falls. We have a slightly different topic each month, and the champions hang these in the bathrooms in their work areas to spark conversation about fall prevention. Now that we've talked about champions and the champion groups, I'd like to tell you a little bit more about what we've learned on our journey in implementing champions, and some keys to success for us include interdisciplinary team members, utilizing pilot projects, having organizational transparency, and leadership support. Despite what we've all been told, great minds don't always think alike, and that's a good thing, probably even a great thing. To get a better idea of the big picture, it's important to use people not only from different areas, but also from different disciplines. We're lucky to have a pharmacist on our team that has specialized in geri psych and is an expert on what medications put patients at a higher risk for falls. We also have a physical therapist on our team who has experience in ICU, acute care, inpatient rehab, as well as outpatient therapy. She's an expert in patient mobility. And without her, it would have been impossible for us to get all of our champions trained in the use of the gait belt. We also have an occupational therapist on our team who is passionate about safe lift injury and preventing patient falls through utilizing safe lift equipment. She has been a big part of making sure that all areas in our organization have the right equipment, and she's been a leader in making sure that the team has the education needed to utilize the equipment in their area. These added perspectives from different disciplines in different areas add to the robust discussion of our meetings, help us to identify system issues, and to establish a plan for bettering our practice. We've also utilized pilot projects. Often when making a change, it can be easy to see something that worked for another organization and just go for it, only to find out later that we spent hours and hours educating, training, and implementing something that doesn't even work for us. With a pilot project, you typically start small and for a short period of time. You're able to evaluate what things are working well, what things don't work at all, and what things need to be adjusted before you move the project forward. You also gain a group of people who can say, yes, this works, it's awesome, and I'm so happy that we're implementing this change. This enables you to have buy-in at the bedside when you move the project forward at a system-wide level. The participants of the pilot also become your automatic experts or super users that can help to train others in other areas when you move forward. For us, we found that piloting was incredibly important when we decided that we needed to change our fall assessment scale. Our fall committee created a subgroup that looked at different validated tools and chose one that they wanted to utilize in our environment. A few units were selected to pilot this tool on paper. The particular tool that we chose helps to lead nurses to interventions based on risk factors. For example, if a patient is found to be impulsive, the tool leads you to use bed alarms, chair alarms, and supervised toileting for that patient. The pilot units found this to be very valuable and felt that it would be great to move forward for the rest of the inpatient areas. So we rolled out on paper this tool to all inpatient units in our organization. Next, we knew that we needed to get this integrated into our electronic medical record. And luckily, we piloted this only on one unit because this was a complex tool and it had a lot of background work and features that didn't really work at first. If we had gone forward at the organization level, we would have lost buy-in and many staff would have become non-compliant and it would have been tough to be successful in the end. But we were able to work out the kinks and get everything working perfectly and smoothly before we rolled this out to our entire organization. And once it was live in our electronic medical record, nurses were excited and happy, and they felt like finally they could chart their fall risk assessment in the same place that they complete the rest of their documentation. We've also found that the ability for our organization to be transparent and sharing outcomes was important to our success. As I mentioned, we talk about our outcome data every month at our monthly meetings using the dashboards with the red, yellow, and green. But we also have a weekly fall call where we review all the falls that happened in our organization in the previous week. We talk about what factors contributed to that fall and what lessons we learned and what we could do differently in the future. All of that has been summarized, sent out to all leadership, as well as to all of our champions, so that everyone is aware of what's going on in the organization in a real way. This has taught our team that mistakes or poor outcomes are just opportunities for improvement. And it's empowered our team members to openly share their experiences. This communication has allowed us to identify gaps in our practice and system issues so that we can make changes to improve our patient outcomes. And finally, we found that there's no way we could have been successful without leadership support. We found that our champions were most successful when their leaders were able to provide them with time, coaching, vision, and a real relationship. It's important that team members are given the time to attend meetings, work on projects, and share information with their other team members. This can be difficult with the competing priorities in today's healthcare, but for us, we found that our outcomes improved when our champions were given this time. It also sends a message to all staff that fall prevention is a priority and something that we need to value. We're asking a lot of our champions. We're asking them to initiate change in their practice area, to interpret and share data, and to give feedback to team members. These are all learned skills that our champions might not be expert at as they begin, and they will require coaching from their leaders to refine these skills. Vision. We also need leadership to provide us with a vision. Here at VCU, our vision is to be the safest hospital in America. And from day one of orientation, team members are taught this. And our leaders support this throughout their day-to-day actions as well as through special recognitions. And one thing I find incredibly remarkable is an award we call the Safety Star. Whenever somebody does something to prevent an error in their area, they are nominated to win a Safety Star award. The winners of this award are recognized on their unit with a celebration. They're not just celebrating how important team members. Through utilizing these strategies, we were able to successfully reduce our fall with injury rate by 80%. We went from having a fall rate that was greater than 0.5 to our most recent quarter, our fall with injury rate was 0.16. At this time, Lynn and I are ready to open up for questions.
Hello, hi. So I've got a good list of questions for you guys, and I'll just go ahead and jump in. So our first question, what risk assessment tool do you use?
Hi, this is Lynn. Thanks for that question. We actually found a tool in the literature that was first developed at UPMC, and it is a 4-question tool. We had previously used Morse, and I think Morgan referenced in her talk that our champions told us when we were at one of our highest rates that even though Morse was a valid tool, it wasn't asking the questions in a way that they could relate them as clearly to their patients despite us doing a lot of education. So we are utilizing a tool from UPMC. I'm glad to share it with you. It was published in the literature probably about 4 or 5 years ago.
Okay, great. And our next question, what about the pilot tool are you using for mental health?
I can also send you that information. We did bring it through the Falls Committee. It is a tool that has been used in inpatient mental health facilities, and they've not brought their data back to us. They literally just started piloting about a month ago. So if you want to email me directly, our contact information is on the next slide, and we'll go ahead and advance to that one so people can see it, and we'll be glad to send that to you.
Perfect. And I have another question, and it's in regards to the same thing of sharing information. Are you willing to share all of your tools and reports with us electronically?
Absolutely.
Okay, great. So everyone can email either Morgan or Lynn to request that information. Okay, our next question. I'm sorry, go ahead.
I just noticed a typo. My last name, it's actually a V where the W is. So I won't respond unless you put a V instead of a W.
Okay, great. We'll go ahead and fix that for you. The next question, how frequently do you assess patients?
So one of the decisions that was made by the champion group, because mobility in our inpatient adult areas is probably the most difficult aspect sometimes to assess, is that we assess on admission. We assess daily with the AM assessment because that's when you're more likely to mobilize your patient and be able to accurately assess their mobility, which is a key part of the assessment tool. We also assess after a fall with a change of condition and upon transfer.
Okay. Who leads the fall call and who sends out the weekly summary of falls?
Typically, so I'm the co-chair on the fall committee, and typically I lead the fall call as well as send out the lessons learned.
The organization that we actually sort of shamelessly stole this process from actually has, they do it at the system level, and so actually have their hospitals call in to do it and review their falls in that format, and they actually rotate who's accountable and responsible for that, but the fall committee has not voted to do that yet. Almost all of our decisions are made at the shared governance level, and at this point they don't want to, for lack of a better word, give up ownership of the fall call and the lessons learned. They're pretty transparent one with another, and as far as who participates in the fall call, sometimes it's the fall champion for the unit, and other times it is the nurse educator or nurse manager for each unit. But as I said, when it is the fall champion on the unit, they, for lack of a better word, really don't cut each other a lot of slack and are pretty quick to call each other if it appears that there is something other than a systems issue going on.
Okay, thank you. Our next question, what are adjusted patient days?
So the adjusted patient days that we use means that we do a fall rate which is across our organization, which includes our ambulatory, our procedural, our ED, and our inpatient. So it includes all of those numbers. So we do a single fall rate for across our organization. We have been benchmarking our fall rate even in the ambulatory and procedural area long before there were national benchmarks to compare them to.
How did you determine your previous tool was not working?
So one of the things that happened, and once again, because we believe in transparency, within a 3-month period of time, we had 5 serious, what we consider serious safety events in which patients suffered more than minor harm from falls. And so we pulled together a number of our clinical nurses from the Falls Committee along with other experts across the hospital and did a root cause analysis of our fall events, and one of the contributing factors was inaccurate fall risk assessment. And when we continued to dig into it, the clinical nurses were the ones that told us that the fall tool was, they thought that one of the reasons that they were unable to accurately assess their patients is that they couldn't relate the questions to their patients, and also that it in essence scored every patient as high risk, so they really weren't able to determine those that were moderate risk versus high risk.
Okay, great. Another question that we have here is, what interventions are you using to prevent injurious falls?
So a lot of the injurious fall prevention really looks at the ABCS factors, and that's actually built into the tool that we use. There is a question that really looks at those fall injury related characteristics, and it counts as a point in the fall tool, and usually is what pushes the patient into the high risk category. And so that is actually what we look at here is age, bones, so either osteoporosis or a known healing bone fracture, coagulopathy that is either medication-induced or disease condition-induced, and then surgery.
And as far as preventing the injuries, the interventions that we have fall mats that we use to put next to patients' beds. We have low beds. Some of our safe lift equipment is designed to help patients who fatigue easily. So if they were going to fall in the bathroom, then we would have a safe lift equipment there to make sure that they didn't really fall as much as they caught themselves on the equipment.
And we also have in limited areas video monitoring that we employ, as well as close observation assistance that round between every 15 and 30 minutes on select patients.
Okay, our next question. I work in the pediatric setting where most of our falls occur when patients are with family. Do you have any experience suggestions with the pediatric rehab setting?
We actually do not have pediatric rehab associated with our organization, but we share that challenge even in the adult, even in the inpatient arena. And so a lot of our focus right now is learning how to better educate and communicate with our young patients' families, because we feel like we're educating them about the risk, but it seems like the things that we thought we were clear about still aren't happening. And in addition, we're really trying to look at the stress that is placed on the So an example is we recently had a fall in our pediatric emergency department where the physician came in to talk to the parents about the diagnosis of the child. And what we determined when we really went to root cause about that is the nurse probably should have anticipated the fact that the parent's attention needed to be in the conversation with the physician at that point and gone in and provided for the safety of the child, rather than assuming that the parent will be a parent at that point caring for the child and listening to the doctor. So we're really trying to develop that level of critical thinking and anticipation of the needs with our pediatric population. And I think it may be a little bit more difficult in rehab than it is in the emergency department, but that's clearly something we're going to employ in the emergency department.
And on the other end of that, I have a question about elderly patients. Do hipsters work on the elderly?
Are you talking about hip protectors? Is that the question? I'm sorry.
Yes, they use the word hipsters, so I'm assuming hip protectors.
I would tell you that we do in a couple of our units use hip protectors. What we have found is that most of our patients really aren't compliant with hip protectors, or those that need them most are actually incontinent in addition to the need for that protection. And so we do not use them as effectively as some other organizations, and I wish that we did.
Okay, great, thank you. How do you use ND and QI fall injury data to drive process improvements and staff engagement?
So, through the transparency of the data, I don't know about you, but a lot of the people on my team are competitive, and so when they see that our unit is not in a percentile that we want to be in, where the staff gets motivated, and also when they see that our fall rate has increased, when they can see a trend line increasing as opposed to decreasing, they don't want to be associated with something bad, and that makes them want to work harder and see what they can do to better our patient outcomes.
And I would add, in addition to that, I really do think, and Morgan touched on it, but for our organization to publicly and privately say that our vision is to be America's safest health system, with what follows that, 0 events of preventable harm to patients, team members, and visitors. Our fall committee, in a surprise to both Morgan and I, decided about 18 months ago to really set our vision at 0, and we are not there yet. We struggle every day with both falls and falls with injury, even though we've made incredible progress. But our champions are currently not happy until we get to 0. And so I think that's what motivates them. They truly believe, even though that hasn't always been the case, that we can get to the point of 0 preventable falls. So we acknowledge, the literature is pretty clear, there are some falls that will never be able to be prevented. But if we can get to 0 preventable falls, then our committee will feel like they have done their work. But my guess is then they're going to try to figure out what else they can do. I have never met a more committed group of clinical nurses and nursing assistants. I think Morgan mentioned this, but I want to make it very clear that we have both registered nurses, licensed practical nurses, nursing assistants on our committee, and our care partners or nursing assistants are the first ones to really motivate and encourage others that we can do better.
Thank you. Our next question. How do you get your patient's family member involved with preventing falls with their family members? Do you have family?
You know, I think that that's a great question, and I'll let Morgan respond as well. But at the fall meeting we just had in September, one of the things that we talked about that we have found is really important, and we're trying to get better and better at it, is really making sure we relate to that patient and family at the individual level. And so it's not enough to say, well, here's your call bell, and remember to please call me if you need anything. It really is finding out what's important to that patient and family and how we can help motivate them to be a partner in safety.
And we utilize TeachBack for our education. So before we leave the room, we ask for the patient or the family member to say back to us, can you tell me what I said, so that we know that they have a good understanding. A patient saying, yeah, I get it, thanks, isn't enough. We need to hear them say, I understand that I'm at increased risk for falls because I was under anesthesia, or for the family member to say, I realize that my family had surgery today and therefore should not be getting up by themselves. I will use the call bell before they get up. And unless they say that, then we can't leave feeling like the patient understands.
Great, thank you. Do your unit champions change on an annual basis?
I think it's a little bit of both. We have some champions that have been with the committee as long as I have, so more than 15 years. And there are other units where really they use it on a rotational basis or a professional development basis. So they may have someone who is a representative for a year, or they may have two representatives and they alternate meetings that they come to, so they both get an opportunity to engage. I would say most champions commit for at least a year, and many beyond that. It just depends on the unit and the dynamics of how they are encouraging their team members to be involved in professional development. There are some units, as I said, though, that have even more than one team member. We have some units that have weekend shifts, and so sometimes they want both someone who works during the week and someone who works on the weekends. Sometimes they have a champion who works days and a champion who works nights. It really just depends on the unit level, and we are not prescriptive about that. And for some units, they can even elect to share a rep between two units. We have a couple of very small individualized units, and so sometimes if those units share team members between them, those two units will only send one representative, but that unit champion knows they still have to communicate with both sets of team members or connect with the leadership of those units.
Okay, great. Where does the Fall Champion team roll into your shared governance?
That's a great question. So our Fall Committee, in fact, all of our nursing sensitive indicator committees, we have a champion model for infection prevention, for pressure ulcer prevention, for falls. They all report to our Nursing Quality and Safety Leadership Council.
Okay, great. Do the champions receive a financial incentive?
No, except as it relates to their performance evaluation. So our performance evaluations are merit-based, and as Morgan shared, Fall Champions and really all of our team members are held accountable in their performance evaluation for the attainment of both unit and organizational goals. And so a Fall Committee team member who is really helpful in moving a unit's journey towards zero forward could receive, in part because of their participation in the Falls Committee, a higher merit raise because of their contribution at the organizational level.
And we have a question here asking if you can restate the risk assessment tool that you use.
Sure. The risk assessment tool was initially piloted by one of the UPMC hospitals.
Okay, so the name of it is UPMC risk assessment tool, or is it anything that can be accessible outside?
Yeah, I don't know of any other name that it has.
Okay, great, thank you. And I have a specific question here. What interventions and changes were made during the period that falls were reduced by 80%?
So the major change that began the improvement was the change in assessment tool. And then in addition to that, it was the restructuring or the information that Morgan talked about, the implementing of the contract with our Falls Committee members, really looking at how we were educating them to make sure that they were unit experts then doing some additional data analysis and really giving it back to them so that they could, as clinical experts, help us figure out where the barriers and systems issues were. I would say those were probably the three most important things that we did. Changing of the tool, really increasing the amount of education and support that our team members get, and then additional data analysis involving them so that we could identify those barriers.
Does your organization utilize sitters?
We do use some what we call close observation. We don't like the term sitter because anybody that we have providing close observation, we don't want them to simply be sitting in the room that feels like they have no direct obligation or contact to engage with the patient or assist the patient. We use a very limited amount of close observation. That's one of the reasons that we implemented video monitoring, because we feel like it is a more effective evidence-based strategy versus close observation, that true what people would call one-on-one in the room. And that has had an impact along with what we did was actually do 2 pilot units at the same time and did simply frequent rounding at the 15 to 30-minute level on one unit and video monitoring on the other, and we're seeing very similar outcomes in both of those units with high-risk patients. So we're still evaluating which of those 2 that we believe will likely be the adjunctive to the use of close observation. We do try to limit that one-on-one in-room close observation to 24 to 48 hours if it's needed, so that we have time to pull together an interprofessional team and really look at what's causing the behavior and how we can then keep both the patient and the team safe depending on what the issue is.
Okay, thank you. Do you think that what appears to be a risk for someone may not be for someone else?
I would say no, because of the way that the questions are asked on our risk assessment tool. The things that are the risk factors are the risk factors. If someone is over age 85, yeah, maybe they're a really active 85-year-old, but now they're hospitalized. So I would say, yeah, they're still at risk, even though prior to hospitalization they were completely independent. And then, Lynn, any thoughts?
You know, I think that that's a great question, and I think that's part of the complexity of getting a fall risk assessment tool that really is, because my experience has been that fall risk assessment tools are only that initial screening that has to happen. It's that nurse assessment and continued evaluation of the patient that then really looks very critically at putting a plan of care in place. So I think at best it's all fall risk assessments are screening tools, and that the individual assessment of the nurse has to be taken into effect. That being said, we still do support a standard of care that doesn't allow the clinical nurse, in light of certain risk factors, to choose not to put certain safety precautions in place. And so I think that there's always a balance between using a risk assessment tool to indicate who might be at higher risk and then using clinical judgment to look at the individual patient. So I wish an easy answer on that. I'm going to say it depends.
And in my experience, I feel that there's never been any harm in overscoring or having too many interventions. Where we do have harm or we do have falls is when we underscore or don't recognize a risk factor.
Okay, thank you so much. Could you share your post-fall huddle tool?
Absolutely. We'd be glad to share all of our tools.
Okay, great. What staff member goes to a post-fall huddle?
So that depends on the unit, but what is asked for on all units is that any available team member, including the interprofessional team members, and then the physician and/or advanced practice provider as available. More often than not, it is mostly clinical nurses and nursing assistants that attend post-fall huddles, but as I said, it really depends on our unit. Like in our palliative care unit, it's not unusual for the entire team to actually come and have that discussion, whereas on other units it may only be the clinical nurses.
Okay, great. Do you do annual fall prevention staff education? What methods?
Sure. We actually call it periodic education, but often provide it on an annual basis. And so that's another thing that actually the team, the fall prevention team, designs. Oftentimes it'll be a couple of fall team members that get together and look at our fall events over the last year, and our education is not the same every year or at whatever periodic frequency we provide it. We try to look at the statistics specific to our falls and say what would help a team member who takes this then help prevent falls in their area. So this past year we really focused a lot on what does our fall profile look like. So what age of our patient falls, what are patients doing when they're falling, what are some of the things we've identified in our fall call that have contributed to falls that we're trying to decrease. And we actually had 3 separate modules developed. So because our ambulatory fall profile looks very different than our inpatient fall profile, looks very different than our emergency department fall profile. So yes, we do. It is at a periodic basis with an attempt at it being annual. And then, as I said, it's developed by the Falls Committee or approved by the Falls Committee before it goes forward.
And it's a PowerPoint that we use in our learning management system. But we also participate in our annual safety fair, where we pick a topic to educate about. This year we're going to be talking about one of our pieces of safe lift equipment, and also our Staxi wheelchairs, which have contributed to multiple falls in the ambulatory area.
Okay, and how often do your fall champions meet?
Monthly.
Monthly.
We meet for about 2 to 2.5 hours monthly.
Have you considered the Joint Commission PSP Fall Prevention Program?
Honestly, no, we have not.
Okay. What process do you use to determine preventable versus non-preventable falls?
So we were honored enough to have Pat Quigley come to our organization a number of years ago and participate in one of our institutes. And we actually use what I will call the classification system that she, to my knowledge, has discussed, lectured on, published on. So we look at anticipated physiologic falls, unanticipated physiologic falls, accidental falls, and intentional falls. And we often consider unanticipated and intentional falls as unpreventable. And I would love to tell you we don't have a lot of intentional falls, but we do. We have a security care unit, which is solely for our correctional patients, that we at many times have what we consider intentional falls. It seems like they like our hospitality a little bit better than their other living arrangements, and so if they know their day of discharge is coming close, they will sometimes place themselves on the floor in order to delay their discharge. So we consider anticipated and accidental falls preventable. But the fall rate that you see posted is all falls.
Great, and I have just a couple more questions for you guys. Thank you for doing such a great job with these. Our last 2 questions. The first one is, do your inpatient med-surg units utilize any sort of scheduled toileting programs with patients?
We do have purposeful rounding, and that's the 4 Ps, and one of the Ps is potty, and so making sure that the patient goes to the bathroom while you're with them at the bedside. And then I know in rehab we do have scheduled toileting, where if we have somebody who won't initiate toileting, we do automatically take them every 2 hours to try to train their bladder and to get them to start to initiate on their own.
A lot of our work around that has really focused on making sure that our team members don't ask a patient if they need to go to the bathroom, but encourage them to go while they're in there, because we had a situation really across the organization where a number of patients, if we simply asked them if they needed to go, would have what I call the road trip effect, and literally as soon as the staff member left the room, I think the power of suggestion led the patient to believe they then needed to go, and because they told the caregiver no, that they didn't need to get up and go, they would then not ring the call bell and try to get up on their own and fall. So we have spent years. In fact, there's probably not a caregiver in the organization who hasn't heard me talk about how to ask a patient to go to the restroom while you're in there purposefully. We do spend a lot of time educating our champions that patients frequently need to go to the bathroom after they've eaten, and that at any point that a patient is woken up during the night shift, that they need to be toileted at that point, because once again, it's sort of that natural reaction that happens when you awake in the middle of the night, you decide you have to go.
Okay, great. And our last question. Several times you have mentioned safe lift equipment. What device do you use in the bathroom?
Oh goodness, now I'm blanking on the company's name.
Well, we actually use equipment that is by Arjo Huntley, and this is not a commercial. But really, even though we do have some very old facilities, our oldest facility was built in the 1960s, is one of our 3 hospitals. We actually are able to use either the TheraSteady, which is the least assistive piece of equipment that we have, all the way up to the MaxiMove in our bathrooms. And because of the OT, the occupational therapist that's on our committee, she has done an incredible job helping our team members realize that what they thought was a barrier and they couldn't use the equipment actually is not a barrier, and so has spent years of her life helping our nurses and care partners feel comfortable using our safe lift equipment in the bathroom.
And the TheraSteady is the one that is most useful for patients who were previously ambulatory but have been hospitalized for a few days and then get up to the bathroom and fatigue while they're in the bathroom. So the TheraSteady is the one that can really help prevent falls in the bathroom.
Well, thank you so much, both of you, for the Q&A. You guys did an amazing job. And everyone, as Morgan and Lynn mentioned earlier, you're welcome to email them with any requests for information that you have. I know that the the presentation materials will be shared with everyone, along with the post-webinar survey. So just look out for that. It'll come to your email, and you'll be able to download this presentation with a link that will be included in that email. So just as a reminder, if you have joined the presentation with a group of your associates and only one person is registered, please email their first and last names and email address to iestrada@posi.com. Each person will receive a webinar survey where the option to receive the credit is available. You will receive the certificate a week after completing the survey. Lynn and Morgan,